to 28 days, so longer ICU stay as compared to traditional RDS. We also found that the patients with a viral shedding, so maintenance of positive swabs at 21 days, at a higher risk of mechanical ventilation and longer length of hospital stay. And so I'm always used to say that at least in the first wave, we treated the unknown, the impossible, and the unimaginable. Really a shocking experience for all of us. The other very important concept that we developed was that SARS is not only a pneumonia issue, as was defined at the beginning. So not only the lung and not only the coagulation issue, but also may affect different other organs, and particularly the kidney in the later phase, the heart and the brain, and less frequently the liver and the gut in terms of critical ills. So that was the reason we defined and proposed the definition of MODS-CoV2, so multiple organ disease syndrome CoV2 virus. And this is an example, again, from our ICU of one patient. This is our colleague's cardiologist, Dr. Valbusa, with the echography, and we always performed echocardiography in these patients. And you see one patient supported by the respiratory system, by the ventilator, and different pumps for metabolic and vasoactive drugs, and the renal support. Most of the patients who require a mechanical ventilation for more than 15 days, they need also renal support. And in this case, also we use ECMO, and eventually we can discuss later the use of ECMO in these patients. Overall, this is our statistics again on 317 patients admitted to the ward with an age of 71 years, so quite old patients. You see that almost 36% developed RDS, and all of them required the non-invasive respiratory support in the ward, and 20% were admitted to the ICU, and all of them intubated. Interestingly, very few patients present septic shock or a need of a CRT at the admittance of the ICU, which is completely different from conventional RDS. In these statistics, you see that the in-hospital mortality was around 43%. So this means that the mortality that we got in the ICU was quite good, and probably, and this will be one of the concepts that I want to focus today, that the best way for this patient is to be intubated very early when they start to deteriorate. The factors associated to hospital mortality from our series were the level of interleukin-6 with odd ratio of 4.4, and of course RDS development or hypoxia development, again 4.4, and the presence of heart disease, very important, high risk for worse outcome, and age was less associated with worse outcome in our series. This is just to discuss very briefly the emerging therapies. This is a review that we published a few months ago. You know that there are different drugs that have been evaluated. Of course, I don't want to enter into detail, but focus on corticosteroid, tocilizumab, and heparin. You know that tocilizumab is an antagonist of the interleukin-6 receptor, and I will not discuss the remdesivir. We did also participated to the study on remdesivir, and you know that actually, at least for critically ill patient, is not recommended, and perhaps there is some role in the initial phase. So this is our experience with early steroids and tocilizumab. This was, of course, before the study in United Kingdom, and you see that we clearly found that tocilizumab associated or not with methylprednisolone. We did not use at that time dexamethasone. With standard of care was much better survival as compared to patients with standard of care. And when we look at the individual effects of steroids, tocilizumab, or combined, we found that trend, although the population was small at that time, of better effects on survival when the tocilizumab and steroids were combined. And these are really breaking news today from NHS in UK, from the recovery trial REMAP-CAP, and they reported that the association of corticosteroids, in this case dexamethasone, plus tocilizumab, 1 or 2 doses of critically ill patients versus corticosteroids alone was associated with a reduction in ICU mortality, 35.8 versus 27.3, and a reduced 10 days of ICU stay. Of course, this is the largest trial. It's not published yet, so it needs a required review, but I think it's very important information. And is a very large population of patients, with more than 800 patients as compared to the previous studies on tocilizumab that, as you know, were not associated with any signal of improved outcome. So this is something to be considered, I think, in the next future, to associate tocilizumab early in critically ill patients admitted to the ICU with corticosteroids. We also found, however, this is another study from our team, that methylprednisolone alone, so corticosteroids alone, were associated with an increased risk of 4 to develop a blood systemic infection, while tocilizumab alone was 1.07, and the association of them was around 10. So we have to consider that when we associate tocilizumab with corticosteroids, we have a higher risk of overinfection in these patients. This is again very recent study from our team, and in 118 patients admitted to the ICU, we found that almost 10% they became colonized or infected by carbapenem-resistant gram-negatives, 5% with Candida auris, and 2% with Klebsiella pneumoniae resistant, carbapenem-resistant. And in almost 90% of patients, infection was not preceded by colonization, and they received a prior treatment with meropenem. And many, almost 2/3 of the patients colonized or infected with Candida auris, they developed candidemia. And however, the crude mortality and the attributable mortality were comparable with other patients. So the concept here is that probably tocilizumab plus corticosteroids might be beneficial in critically ill patients. This might be associated with an increased risk of overinfection, but the positive effects of anti-inflammatory effects of these drugs as compared to the increased risk of overinfection is balanced in favor of anti-inflammatory effects. So this is an important concept, I think, in terms of general management of these patients. The other important issue is the Anticoagulation Protocol. This is our protocol, which was just published, and we use since the beginning. And as you can see here, we divided the patients in 3 different groups with low risk, intermediate risk, and high risk, according to the D-dimer less or higher than the 1,000, and the presence of clinical events or not, and the presence eventually of increased BNP troponin or alteration at the electrocardiogram and clinical events. According to these 3 categories, we use a prophylactic enoxaparin at 4,000 a day, or therapeutic enoxaparin at 4,000 times 2, or 6,000 times 2, or 6,000 times plus 4,000, or intravenous heparin at 20-25 units a day. And you see here that this was associated with the evaluation of the echocardiographic right heart impairment, and in case we performed the CT angio, and in case we found a macroembolism, we used also thrombolysis in very few patients, only 6 or 7 patients, with very positive results. In case that we use therapeutic enoxaparin and or intravenous heparin, we continued, or thrombolysis, we continued with new anticoagulants in the follow-up after a period with warfarin. On the other side, we continued in all the other cases enoxaparin for 1 month at a prophylactic regimen, 4,000 a day. We monitored the coagulation with the dimer, of course, 1 or 2 times a day with activated factor 10, especially when we use enoxaparin, and the thromboelastogram in other patients. Now we go back to the lung and what we learned from the lung. We know that since many years, and this concept was developed with Professor Rocco in Rio de Janeiro, years ago that we have classified RDS in pulmonary RDS when the insulin is directed to the lung. Its most common cause is the pneumonia, or extrapulmonary RDS when the lesion of the alveolar capillary barrier is coming from the extrapulmonary foci and inflammatory mediators, and more typical from sepsis. In normal condition, it's not easy from clinical point of view to separate pulmonary and extrapulmonary RDS, so it's more difficult correct classification. From anatomopathological point of view, we found that pulmonary RDS as compared to extrapulmonary RDS was characterized by higher damage of the alveolar epithelium, with prevalent alveolar neutrophils and apoptotic neutrophils with presence of fibrinous exudates, but lower alveolar collapse and prevalent local interleukin. On the other side, we found an interstitial space was characterized by less interstitial edema in pulmonary RDS as compared to extrapulmonary RDS, but with increased collagen fibers, which is also related to the possible beneficial effects of early corticosteroids. The capillary endothelium was almost normal in pulmonary as compared to extrapulmonary RDS, and while in the blood, inflammatory mediators were much more increasing in extrapulmonary as compared to pulmonary RDS. We did a cryobiopsy in COVID-19 patients. This is a very particular technique. As you see, with a fibroscope, this is a technique which is particularly used for monitoring and biopsy for tumor. And so we were able to perform cryobiopsy in patients who died by COVID-19 just after 20 minutes after dying and during mechanical ventilation. So our data are completely different compared to the conventional autopsy study, in which the analysis of the lung is performed without mechanical ventilation and with some days after the death. What we found was that we analyzed patients more or less who died at 25 days, because our length of ICU stay is quite long, also in patients who died. And we were able to compare the anatomopathological findings in different parts of the lung with the CT scan. And we found different patterns, the so-called early death pattern, you can see here, with an alteration in the alveolar membrane, you see in the black arrows, with the lesion of the epithelium, and with the presence of hyaline membrane, and with not much edema. When we look at the CT scan, which appear gray, a little bit gray, but not particularly affected. Amid that pattern, when we found a ground glass alteration, and as you can see here, you start to have a complete alteration in the lung structure with initial fibrosis of the lung. Then in the white areas, we will so-called late dead pattern, which we do not recognize anymore any structure in the lung, with a complete pneumolysis and vascular lysis with minor thrombosis, and the so-called honeycombing in the lateral region of the lung at a very high risk for pneumothorax or pneumodiastino. In this patient, when you see a complete alteration of the structure of the lung, and in blue, mucosinosis with infiltration of the alveoli, and very instantly in the fourth box, the thickness, increased thickness of the extracellular space. And you see these long, smooth, long cells, red cells are smooth muscle cells, which demonstrate a complete disorganization of the fibrotic response. So from our study, we found that there was less thrombolysis, likely because we use a very strict coagulation protocol, but we found pneumolysis, vascular lysis, alveolar cell infiltration with mucosinosis, and major fibrosis at 25 days. We identified that the CT scan three type of phenotype. The first one is, you see here, was a multiple focal overperfused ground glass opacities associated with normal aerated areas, and this lung may be treated with non-invasive respiratory support. A phenotype 2 with initial presence of inhomogeneously distributed atelectasis and peribronchial opacities, but more importantly, a further development in the phenotype 3 with patchy RDS-like pattern, unhomogeneously distributed with hyper and hyperperfused areas associated with phenotype 1. In the ICU, in the critically patients who require intubation, we found that phenotype 1 is rare, and in fact I told you that phenotype 1 is usually treated with non-invasive respiratory support, while phenotype 3 was more frequent and may evolve in pneumolysis, vascular lysis, fibrosis, and complicated with overinfection. So this is the pattern, typical pattern of the patients that were admitted to intensive care and required intubation. The other important point is the fibrosis after COVID-19. This is one of the first patients that we extubated and we treated with non-invasive ventilation, and this was also on the TV news a month ago. And you see the CT scan when the patient were intubated, and this is the CT scan when we extubated the patient. You see major alteration with fibrotic or fibrotic-like alteration. The issue is that we are now following up the patient, that it seems that at least in 2/3 of these patients, this alteration that were very worried for us at the beginning were partially resolving with time. So this is something that we have to learn in the next months, but it seems that at least in 2/3 of the patients, there is a partial resolution of this alteration in the lung. The other issue that we focused on was the distribution and the role of regional perfusion to determine VAQ and shunt and to explain the pathophysiology of COVID-19 patients. You know that perfusion may be important, is important to characterize area of high VAQ areas, mainly in the non-dependent part of the lung, the low VAQ areas in the middle part of the lung, and the shunted areas or non-aerated perfused in the dependent part of the lung. And you have 4 different characterizations for regional perfusion, which may be affected by vasoconstriction, swelling of the endothelial cells, obstruction with microthrombosis, and collapse. This is the typical distribution of perfusion in the traditional RDS, and you see in red more perfusion and in blue less perfusion, and you see that in most of the patients the distribution of perfusion is gravity dependent when atelectasis and densities are present. And in fact, there is a correlation between the PO2 FO2 ratio and the proportion of perfusion to the voxel with fractionated water higher than 0.7, so non-aerated lung regions. So in traditional RDS, in the dependent lung region, we observe consolidation in atelectasis characterized by gravitational regional perfusion. So hypoxia in this patient is due to true shunt and not low VAQ in most of the cases. So we decided to perform the dual energy computed tomography in order to evaluate the blood perfusion and mainly the blood volume, which is associated with perfusion in these patients, and correlate with the aeration and tissue in these patients. What we found is that normal lungs are characterized by the lung weight of 800 grams, while the RDS lung is 1,800 grams, with an excess tissue RDS of 1,000 grams. And the COVID-19 phenotype 1 is associated with 1 kilo and 100 grams with an excess tissue of only 300 grams. So phenotype 1 is characterized by lower increase in the lung tissue, lung weight, while the COVID-19 phenotype 3 is characterized by very high lung weight, more or less similar to the traditional RDS with an excess tissue lung weight of around 800 grams. So when we look at the distribution of pulmonary blood volume from ventral to dorsal in supine position or from the apical to caudal lung region, you can see here that there was not a gravitational distribution of the pulmonary blood volume and perfusion, but an anti-gravitational distribution. So the distribution of blood volume and perfusion in COVID-19 is higher in the ventral compared to the dorsal RS, so anti-gravitational, and is higher in the apical with less densities as compared to caudal with more densities, completely different from traditional RDS. Then we look at, we were able to compute the amount of shunt in these patients, and where the shunt, how much shunt was percentage in the different areas of the lung. You can see here in the black, in this case are survivors and non-survivors, that the black area is around 10% of shunt, and of course with a large range, but quite low as compared to traditional RDS, which is around 20 to 25 or up to 30% of shunt. And you see that almost 50 to 60% of the shunt is explained in the non-aerated lung. So means that 60% of non-aerated lung is perfused, but this also means that almost 40% of non-aerated lung is not perfused. Then we look at the gas-blood volume ratio. So this is more or less the VAQ ratio. And I would like to focus your attention on the yellow area, so the poorly aerated areas. You see that less than 1 means low VAQ areas, higher than 1 means high VAQ areas. And you see here, first of all, that 2/3 of low VAQ areas are characterized in the poorly aerated lung regions, which are also characterized by 1/3 in the high VAQ areas. And patients who do not survive are characterized by a higher amount or high VAQ areas in the poorly aerated lung tissue. Finally, we look at the perfusion defects in the whole lung and in the hyperaerated, normally poorly and non-aerated lung. First of all, the dead space. The dead space means the area of high VAQ. And you see here that the highest amount of high VAQ, so dead space, was found in the poorly aerated areas. So the poorly aerated areas play in the COVID-19 a very important role as compared to traditional RDS, characterized low VAQ areas and high VAQ areas with dead space. We also found that almost 20 to 30% of non-aerated tissue is characterized by non-aerated, non-perfused lung regions. So in the non-aerated areas, we have almost 50 to 60% perfused, and this is due to the shunt, and 30 to 40% non-perfused, which is in some way a sort of protection towards a further increase in shunt. When we correlated normally aerated lung mass with oxygenation, we found a quite good correlation, but most importantly, when we correlated aeration perfusion mismatch, which is the sum of low VAQ areas, shunt, and non-perfused, non-aerated areas, you see that we found a very nice correlation with PO2-FR2, but we found that true shunt was independently associated with PO2-FR2. So when we have a development of the hypoxia, or more severe hypoxia, means that we have a development of true shunt, so means that we have an increase in the white areas, non-aerated areas perfused. This is just an example of patient in non-invasive respiratory support, like a Phenotype 1, with more or less reasonable transpulmonary pressure, tidal volume, respiratory rate, oxygenation, and compliance in CO2. Just after 1 day, just to give you an example, you see that we have a movement shift from Phenotype 1 to Phenotype 3. So in that case, you see that we have an increase in transpulmonary pressure, a decrease in compliance, increase in respiratory rate, and decrease in oxygenation and the PCO2. So as soon as we see an increase in respiratory rate and a decrease in oxygenation, this means that we are shifting from Phenotype 1 to Phenotype 3. And in this case, we should promptly intubate the patient and not delay the treatment in non-invasive respiratory support. We also investigated the role of PEEP in this patient, PEEP8 and PEEP16, and we found no major changes in the lung weight at the change of PEEP, so it means that there is no redistribution of water. And when we look at the distribution of frequency, as you can see here, there was no difference. So overall, we found that there was no major increase in the normally aerated tissue or hyperaerated tissue, only 3 to 4%, and no major decrease in poorly aerated tissue and non-aerated tissue. So overall, we found that there was poor alveolar recruitment with higher PEEP from 8 to 16 in this patient in less and more severe cases of COVID-19 pneumonia. And you see that the recruitable tissue in Phenotype 3 was only 30 grams on average, which is equivalent to only 4% of the chest tissue, while in traditional RDS is around 200 grams, which means almost 20% of the chest tissue. And the potential for recruitment was not different in patients with phenotype with low compliance or high compliance. So rescue mechanics does not predict the amount of recruitment in these patients, and also was not different between patients who developed VAP or between survivors and non-survivors. We also look at the effects of oxygen response at low or high FiO2. And you see here that we found even higher PO2 when we use lower PEEP level with higher FiO2 as compared to lower FiO2 with higher PEEP. So higher FiO2 is very important to improve oxygenation much more than the increase in pressure. The shunt only slightly decreased when we increased the level of PEEP, but more importantly, most of the patients decreased the respiratory compliance or increased the driving pressure when PEEP was increased from 8 to 16. So we found overall that higher inspired oxygen fraction is more important than to excessively increase PEEP level to improve oxygenation in these patients. Another issue is related to the use of prone position. We've developed this model years ago, and you see here a case of a patient in which the patient is prone. There is no redistribution of densities. The oxygenation improves, but there is no change in regional ventilation, so there is no change or even an increase in PCO2. In this case, the improvement in oxygenation is fully explained by a redistribution of perfusion and not alveolar recruitment. In another case, you see a patient in which we have a real increase in the amount of recruitment. So the PO2 increases because there is an increase in the recruitment and regional ventilation, and this is mainly associated with a reduction in PCO2. We perform a CT scan in supine and prone position in a limited number of patients, but almost 15 patients, and we found that there was no change in the amount of densities. So we believe that the improvement in oxygenation is mainly due to a flow diversion and not alveolar recruitment. This is overall our experience in the first wave with prone position. We found similar results in non-invasive and invasive mechanical ventilation, and prone position during non-invasive ventilation may even delay the intubation, so we don't like to use for a long period of time. Prone position was used in almost 1/3 of the patients. 61% improved oxygenation, but most of them, they deteriorated when rest position at supine. And at least half of the patient increased the PCO2. So it means that the effect of perfusion is very important. And of course, prone position is associated with an increased healthcare professional demand and workload. And more importantly, we have always to exclude thrombosis and possible pulmonary thromboembolism before proning the patient. These are data with helmet and prone position. You see that there is a minor increase in the PO2, which is reduced when the patient is repositioned supine. So overall, we do not suggest to use prone position for a long time, even during non-invasive ventilation. Now I would like to share with you our model of a conventional RDS. This is quite clear. So we have a diffuse alveolar capillary injury with edema, increased weight on the superimposed weight on the dependent lung region with atelectasis, lower compliance with higher perfusion in the dependent lung regions, with major recruitment with higher pressure or prone position in most of patients. So the response in oxygenation is associated with better aeration, recruitment, but not perfusion redistribution. In COVID-19 patients, we found, as I show you, that the pathophysiology is completely different. And you see here that two models for type 1 and type 3. And in the dashed areas, you see consolidated areas and not atelectatic areas. And in the blue circles, you see the ground glass areas with some thrombosis and some hyperperfusion. And as I told you before, we found that COVID-19 is a typical primary RDS with pneumovascular lysis, with exhaust volume substituted by cellular infiltration and fibrasis, with consolidation, and with higher perfusion in non-dependent lung region, which is associated with a reduction in VAQ, and with poor or no recruitment with higher pressure or prone position. So the response in oxygenation was associated with a redistribution of perfusion and not better aeration, both with PEEP and flow. Hypoxia may be explained in this patient by low VQ in poorly aerated lung tissue due to hyperperfusion, as I show you, due to the non-gravitational distribution of perfusion, with high shunt in non-aerated lung tissue, with microthrombosis and vascular lysis effects, which may be partially protective, and high VQ in poorly aerated lung tissue due to hypoperfusion with an increased ventilation ratio. So we can explain hypoxia with low lung weight, low recruitability, with high compliance and low inspiratory effort, with low VQ and high dead space in the poorly aerated tissue, which is a good oxygenation response to IFI2. Conversely, in unhappy hypoxia, we have patients with high lung weight, with low recruitability, low compliance, with high inspiratory effort, characterized by high shunt in the non-aerated tissue and very low VQ RS and very high dead space in the poorly aerated tissue, with poor oxygenation response to IFI2 and high pressure associated with very high increased ventilation ratio. So we suggest to use these patients at minimal pressure to ventilate these patients and to just gently ventilate the aerated lung, keeping the consolidated lung, not the atelectasis, because these patients are not characterized in most of cases by atelectasis at rest, and use minimal saturation, 88–95%, with PO2 between 55 to 80 millimeters of mercury at minimal PEEP in order to minimize possible right ventricular impairment, which may be very important in this kind of patients. We have to consider that if we use this minimizing the oxygen therapeutic approach, the Bohr effects, so we lower saturation at lower pH and higher PCO2 with low or high PCO2, PO2, and so we use sometimes and more frequently the respiratory dialysis of echo2R or independently or by using associated by a CRRT when needed. We also have to consider the hemoglobin, and you see here some calculation regarding the oxygen transport and PO2 at different level from 50 to 90, a different level of hemoglobin to 7 to 13. And as you can see here, we found that if cardiac output between 4 to 6, we have to maintain hemoglobin between 10 to 13, and only if cardiac output is very high, we can accept hemoglobin even lower at 7. So the suggestion is to use this minimal level of oxygenation with higher level of hemoglobin to optimize oxygen delivery, and then be some role of erythropoietin in this patient, even when not intubated. These are very, very recent data which are going to be submitted from Chiara Roba, again from our team, and I will show you very rapidly. You see here the pre and post in terms of oxygenation, PO2, PCO2, SO3 is the oxygenation in the brain by Maximo, and the evaluated intracranial pressure by non-invasive technique. First of all, look at the recruitment maneuver. Recruitment maneuver, we found a decrease in, no improvement in oxygenation, no change in CO2, but we found a decrease in the oxygenation in the brain and an increase in the estimation of intracranial pressure. So be careful about recruitment maneuver in these patients. What about prone position? We found in this series, this is the second wave, an increase in the PO2 in a limited way, as you can see here. We found no major changes in CO2, just a little bit increase, but we found an increase in oxygen in the brain and a slight increase in intracranial pressure. So in patients without any problem in the brain, the prone position was associated with an improvement in oxygenation, improvement in cerebral oxygenation. What about nitric oxide? We had a very favorable experience with nitric oxide in these patients. You see that these were associated with an increase in oxygenation in blue, with no changes in CO2, but an increase in oxygenation in the brain, and even a decrease in intracranial pressure. So while the prone position was associated with improvement in oxygenation, but in increase in intracranial pressure within safety limits anyway, with the INO, we found an increase in oxygenation, just a little bit less than what we found in prone position, so very effective, with a decrease in brain intracranial pressure estimation. When we use the ECHO2, you see here that we found a major decrease in the PCO2, with no major changes in the intracranial pressure and a slight decrease in the PO2, but this is because probably the pH, which increased due to the major decrease in PCO2, was increased, and our hypothesis is that faster increase, quick increase in the pH may affect pulmonary vasoconstriction, but this is something that we have to better investigate in the future. So rescue therapies in critically ill patients might be effective, but we have to know the specific pathophysiological mechanism with different effects on systemic and cerebral oxygenation, and we have to choose. The choice of ventilator strategy should consider both lung and brain oxygen needs. So overall, I believe that one of the best treatments for non-invasive in the HEPA hypoxia, as I showed you before, is to use high flow oxygen nasal therapy because we don't use pressure non-invasively. And when we are going to phenotype 3, so unhappy hypoxia, we need early intubation. This is our guidelines for a non-invasive respiratory support. As you see here, according to the saturation, we performed an oxygen test at 50 liters per minute with reservoir. Then if the patient maintained a lower saturation, we started high flow oxygen nasal therapy or CPAP by helmet. And according to the response, we moved to intubation or not. Of course, also accessory muscle activity, reduced PCO2, and eventually lung imaging might be extremely helpful. We avoided the intubation by high flow oxygen nasal therapy, that in my opinion is the first choice in these patients, and non-invasive CPAP in almost 65% of the patients. It was also reported by the group from Monza recently on PubMed. Overall, I think this is a very important concept, in my opinion. Don't delay intubation if you progressively deteriorate in terms of oxygenation and respiratory rate. This is, in my opinion, the easiest and the cheapest way to save lives in COVID-19 patients. Another very important issue is the weaning procedure. This is our protocol that we published and validated, and this is related to the spontaneous breathing trial. And you see here that when the patient passed immediately the first spontaneous breathing trial, we extubated, followed by CPAP or high flow oxygen nasal therapy. If the patient failed the first attempt, we performed a rest period and then performed a second attempt with a minimal level of pressure support. And when patients were extubated at the second attempt, extubation was followed by non-invasive ventilation. The important concept here is that respiratory physiotherapy is very important in this phase of these patients. And we also organized a post-extubation intermediate unit where we maintained patients for at least 3 to 10 days after ICU, monitored by anesthesiologists, our team, because we found that almost 30% of the patients may develop complications after extubation in the ICU. So these are my last 3 slides. COVID-19 is a real serial killer, is a very systemic complex disease, not only affecting the lung, is not traditional RDS in my opinion. As I show you, the first bullet is pneumonia, characterized by what I can define primary RDS with typical pneumo and vascular lysis. A second bullet is coagulation for thrombosis and eventually local hemorrhage. The third bullet is fibrosis, but our recent data suggests that this might be solving at least in a certain number of patients with time. There are 3 main targets: anti-inflammatory, corticosteroids, methylprednisolone are 1 milligram per kilo and then tapered off, or desamethasone at 6 milligrams for 10 days. And this very recent data might suggest that we could add tolicizumab, but we 1 dose or 2 doses. But remember that we have to monitor carefully the overinfection, as I show you. The anticoagulant protocol is very important, from prophylactic to therapeutic, and protective respiratory support from non-invasive to invasive. So local protocols are very important. From physiopathological point of view, I showed you that in critically patient phenotype 3 is more frequent than phenotype 1. There is an inhomogeneous pattern of aeration, blood volume distribution, and perfusion defects. The pulmonary pattern, blood volume, and perfusion defects were associated with clinical outcome and inflammatory and thrombophilia markers. The epipoxia is characterized by high compliance with low effort and low VQ in the poorly aerated tissue, which is very characterizing in COVID-19 patients, and high dead space and ventilation needs. And the unhappypoxia is characterized by lower compliance with higher effort and high shunt in the non-aerated tissue and very high dead space and ventilation need in the poorly aerated tissue. So how to ventilate COVID-19 patients? We have to be very patient because these patients need at least 1 week more than traditional RDS. In phenotype 1, non-invasive respiratory support might be helpful, but early intubation is mandatory in my opinion if no clinical improvement occurs between 3 to 6 or 12 hours of 1 day maximum, a respiratory rate higher than 28 breaths per minute, saturation below 95, we have to a 60%, PCO2 lower than 30, and accessory muscle activity. In phenotype 3 or phenotype 1, not improving in non-invasive respiratory support, I think that we should early intubate and initiate controlled mechanical ventilation by using protected tidal volume between 6 to maximum 8 milliliters per kilogram predicted body weight, a plateau pressure below 25-27, and a driving pressure below 12 to 14 centimeters of water. Use moderate level of PEEP between 8 to 13 centimeters of water and maximum 15, and use more higher FiO2 as compared to higher PEEP pressure. I suggest to minimize oxygenation targets with targets between 88 to 95%, with a PO2 between 55 to 85 milligrams of mercury, with an hemoglobin likely higher at least than 8 grams per deciliter to optimize oxygen transport, and consider the possible effects of both effects on saturation by PCO2 and pH control. In phenotype 3, we can consider inhaled nitric oxide, we can try prone position, but we have to remember that in most of the patients, prone position is associated with improvement in oxygenation, but due to perfusion redistribution and not really alveolar recruitment. And we have also to consider the higher risk of increased PCO2 and lower pH, and again, the possible both effects. So in some patients, we can consider respiratory dialysis of echo2R at 400 milliliters per minute in order to minimize the workload, the mechanical workload of the ventilator. And recruitment maneuver should be used only as a rescue. So I hope to have given you really our almost very comprehensive experience from therapeutic management of these patients and what we found in terms of pathophysiology of the COVID-19 pneumonia, and what we believe might be a good suggestion, of course, open for discussion to optimize and individualize the ventilatory treatment in these patients. Thank you very much.
Thank you very much, Paolo. That was great. That was great as usual. Many thanks. We are waiting for the questions in the chat box. I have one question from Mukadder, my friend in anesthesia. What are your suggestions? So considering that you have said that there can be some also some late time up to 12 weeks complications, how to behave in COVID, in anesthesia of post-COVID patients?
In post-COVID patients, I think, I mean, of course, we have this data in the follow-up, and most of the patients at 3 months, they partially, 2/3 of the patients, they partially solved these lesions. So these lesions are, we call fibrotic, but probably is not like the fibrosis that we have in mind. Now, this is something that we are trying to understand better, and because the true fibrosis is solved, is not solved, while this is probably some is fibrosis, but other is some like fibrosis, but is probably viral fibrosis, and then there is some healing. So what I suggest is that anyway, a patient who require, there are 2 kinds of patients. The patients who are going to have anesthesia and you find a positive jumps, and in this case, if the patient had not respiratory symptoms before, we are almost sure that there is no major effect in the lung. So the lung is like the conventional lung. It's only a question of organization. That was we were discussing before, to go in the unit with COVID protected and like this. We always perform, always a molecular antigen, fast analysis, and then we perform takes 3, 4, 5 hours from the BAL or BAS, always in anesthesia. Before anesthesia, a rapid molecular. The antigenic fast we don't use for these purposes. This can be discussed. So we always perform a fast. This is very important in my opinion. We don't use the antigenic fast because we don't know, especially because if it is negative anyway, you are not sure, you have to do the molecular. If it's positive, you are not sure anyway. So we prefer to do the fast molecular, and then we always try to confirm with the conventional molecular. If the patient has not respiratory symptoms, we know that the lung is not majorly affected. If the patient is coming, now we will see more of these patients. So with some COVID, previous COVID, I think it depends how much COVID. I mean, if you had only positive and no hypoxia, no respiratory symptoms, again, I don't think we need anything. If the patient had some more severe respiratory symptoms, so he was hospitalized, or even he required more non-invasive support, we are not talking even about intensive care, perhaps I think that what we are doing is to do a pulmonary function test at least, and to evaluate at least the saturation in air. So simple test. I'm not saying to do a CT scan, but I think that in election, at least a pulmonary function test, we found that, for example, the LCO is altered in most of these patients. We don't know what we know is that if you have the COVID and you are going to be the risk to develop PPC 5 times more. So it's a patient that, in my opinion, if it is a patient with some initial respiratory symptom, or a patient with some need of respiratory support in the past, and now he requires an intervention, I think that should be very carefully evaluated, because we know that the risk to develop complication is higher than conventional patients. In terms of ventilation, exactly as you know what I think about ventilation anesthesia, very, very gently, low pressure.
Okay, got it. Okay. I will give the word to Nahid Shekar, but before I will give him the word, but there are several questions. I will ask 2 of them, and then I will give the word to Nahid. First one, just 2 questions, and then we will continue with the other questions. I will ask all the questions as far as time permits to us. The one is from Burcu Tufanoğulları. She's asking, how long do you use prone position? And the second one is from Gianluca Paternoster. You know him probably. Is there any difference in cardiovascular involvement in different phenotypes?
Yes, so for prone position, we used more or less when possible, when we did not observe an increase in PCO2, because this was the difference compared to traditional RDS, the increase in PCO2 in prone, in more patients than in traditional. We used it for 12, 14 hours, as usual. But no more than 2 times maximum. No, not very. We did not use prone position very aggressively because
3 times
maximum
12 hours.
Yeah.
So okay.
Yes. Because then most of the patients, they lose in supply, so we just use as a rescue. So we did not use it mainly as a therapy in our experience. However, maximum 3 times. In RDS, we were using even up to 5. In this patient, maximum 2 to 3. That's the first point. And we use that only when we mainly when we found a real phenotype tree. So when we had collapse or consolidation in the dependent lung. If there was not, we use much less frequently. So the CT scan was very helpful to decide which patients. Regarding the heart, I can say that we perform echo in almost all patients. We have also some studies about the echo. I can tell you that echo is very important, mainly to evaluate the right ventricle, because the left ventricle is not affected. Then if you go biopsy, you can find some inflammation, but mainly it's the right ventricle. Personally, the hemodynamic is not a problem in the early phase. So in the early phase, if you have a problem in hemodynamic, it's because we have a gross thrombosis. So there is no problem. For the microthrombosis, you never find an involvement of the right ventricle. That's why this question of thrombosis, we look at the dimer, we can discuss, but it's part of the story. It's not the story as someone wanted to. So the problem, why to analyze the heart? Because the problem is that if you don't improve oxygenation with PEEP, our experience, or people are prone or whatever, or with time, or you deteriorate, we found that one possible cause was a thrombosis. And in that case, we manage by echo, and by echo by CT angio, and from CT angio eventually thrombolysis. But in terms of hemodynamic, so cardiac output, there is no major problem. The problem may occur later when you have a infection and you go to have sepsis. But I show you that in the early 12 days, before the first 12, 13 days, I have also a slide on that. We did not observe any problems in terms of infection. When you develop sepsis and renal function, renal is after 12, 15 days. But this is another issue. You are becoming a late patient's COVID with sepsis. But in terms of hemodynamic in the early, I don't think it's a major issue. It's an issue for the right ventricle.
Okay, thank you. We have some 10 questions here, but Nahid Chakar is the co-host and he will probably say something.
Thank you, Mert. Hi, Paolo. It was a great talk as always. But I have some questions, and I have to start from the phenotype one. I observed that you are insisting on phenotype 1 and phenotype 2 and 3 issues. I want to ask, in ARDS definition, I already asked you this question priorly. In ARDS definition, we don't have any phenotypic alteration. Probably in that definition, we tried to gather all of these ARDS types in one definition and try to defining after ARDS, try to define ventilatory issues. And with Berlin definition, we have, by giving that ARDS diagnosis, we were using protective ventilation.
Alo.
And we were separating the patients in...
Doktor Müşerref ben, Ceren Akın yakınıyla görüşüyorum değil mi? Bilgi vermek için aradım.
One severe, moderate,
Celal Bey'in durumu stabil.
mild ARDS.
Tansiyonla ilgili.
And with those definitions, we reached to the conclusion that in mild cases, we may use non-invasive ventilation. But when it comes to the moderate cases, we try to intubate the patient. What is different from these decisions in COVID-19, and should we change ARDS definition after this COVID-19 pandemic ends?
Thank you very much, because
this is the first question. Okay.
Yes, because we are back to the pathophysiology.
Okay.
Why I think is important to understand what we call phenotype 1 and 2, but not in terms of only lung structure, but also perfusion. Because here, as I showed you, in the phenotype 1, you have ground glass, so you have no atelectasis, no consolidation, it's only gray areas, more or less, of course, and these areas are over-perfused. This is, to me, is the difference compared to RDS. We never observed it in RDS. Ground glass only, hyperperfused. This means that the VQ is low. The low VQ, except few data, you remember Dansker in some few patients, but usually RDS is shunt. So it's consolidation or atelectasis and perfusion. That's RDS. Low compliance, more or less, and shunt. Here we have a particular situation in which the compliance is relatively good in the early phase, but you are hypoxic. Why you are hypoxic? Because you have the low VQ of the ground glass, which does not affect compliance, but affect the oxygenation. So this is the first. So we have something completely, in my opinion, different compared to the traditional RDS. Because if this ground glass would be edema, the lung should collapse because the lung weight should increase more and you should have the collapse, and you don't have the collapse. What to me is very important is that if you look at the white areas, even in the what I call phenotype 3, you have black area in the white areas. This means that these black areas are consolidated areas. If we collapse due to edema, they should collapse. You never see in the traditional RDS black holes in the white areas, never. Because to me, so to me, the phenotype means that one is a lung with the COVID that is start to work, you are hyperperfused, you start to have deterioration of oxygenation, but you respond well to oxygenation because it's simply low VQ. And why is important? Because this patient may be treated with non-invasive respiratory support. But if you develop desaturation, and this is associated with an increase in respiratory rate, more or less, but desaturation, so means that you give oxygen 60, 70, and you don't. In that case, in my opinion, you are moving to the other phenotype. And in these patients, in my opinion, the best way is to intubate. Now we are doing a study looking at all our CT scan. We have patients intubated within 24 hours and patients intubated much later. There is a huge difference in the CT scan because the lung is started to deteriorate. So to me, more than whatever drug, corticosteroids, tolicizumab, remdesivir, whatever you want, to me, the best way to save lives of these patients is when they start to deteriorate. So they move, the CT scan is just to show what's really happening from one side. And I agree with you. What's different from traditional RDS? The pathophysiology is different. But we were used not to use non-invasive ventilation for a prolonged time if you start to deteriorate. Well, in this patient, for different reasons, we maintained longer non-invasive ventilation. And this, to me, is very bad for these patients. So we should, this data reinforce the concept that non-invasive ventilation in hypoxemic patient, and this is a particular type of hypoxemia, should be used for a short period of time if you do not improve oxygenation. In terms of Berlin definition, Berlin definition is a clinical definition, very wide definition, does not enter into the specific pathophysiology. The COVID-19 helped us, in my opinion, to understand more that hypoxia may not be due only to shunt, but may be due to low VQ. And this is something that we have in mind, in my opinion, only for COPD that are typical for low VQ. And in fact, they respond very well to IFL2. But we are used to treat RDS, the traditional RDS, which does not respond to IFL2. While here, we learned that perfusion plays a role. In fact, my effort in the next 2 years will be to go back to perfusion in traditional RDS. Because I think that probably we lost something in traditional RDS. We were just biased by the concept that traditional RDS is only through shunt. Perhaps it's true, but perhaps we lost something related to the Lobia Q. In my opinion, if you have Lobia Q, you can be treated very simply. Lobia Q you can be treated by non-invasive. If you have true shunt, you have to be intubated.
Mert, if you are getting questions, I will let you, but I have one short question concerning the timing of tocilizumab used in ARDS patients, and I'll add something to this question. In late cases of ventilated in ICU, which we could not wean off the ventilator, they have some sequelae of COVID-19 in the lungs, and these are high to treat cases. Do you have any suggestion for their ventilation period in late ventilated COVID-19 patients?
So
and
regarding
timing of tocilizumab and use of steroid in these cases.
Yes, yes. Now, we used steroids since the beginning, since we used methylprednisolone because there was no study on dexamethasone. I'm not convinced that the study was only, the British was just because they used dexamethasone, but I think that if you do with methylprednisolone, you get similar results. It's corticosteroids per se. But we started immediately, early, and tocilizumab we did in our hospital immediately. So very early when the patient started to deteriorate. And this study from UK that I showed you just appeared today in no non-peer review, but was open for access. They treated the first day immediately in the ICU. So I think that anyway, this drug should be used very promptly. So it cannot be used after 1 week or 3 days. It has to be used very early. Otherwise there is no effect. Again, I think that corticosteroids are in general more effective, but this data suggests that we have to rethink the use of tocilizumab. We start, as you say, we have seen we use since the beginning tocilizumab in some of our patients, and we got the results that I showed you very favorable. So I am in line with what the British found reported yesterday. Regarding I think that this is very important. So to me, it's corticosteroids. We know that remdesivir, for example, we don't use anymore in acute care. Remdesivir, we use in patients in the ward very early, but we don't use anymore in the critically ill patients. Regarding the question of follow-up, of the lung in the more severe, in the ventilation in the patient with longer, we try to go down with people. We start with low level, moderate level. I showed you no more than 15, and we try at that point at 10, 15 days. Most of our patients they no more than 10 centimeters of water of PEEP. So we try to initiate assisted ventilation or in we call BiPAP. I mean BiPAP PRV or pressure support as early as possible. So our strategies was, since we used since the beginning corticosteroids, we try to use as less as possible neuromuscular blockade. That's the reason why we use less frequently prone position, because prone position is and for a short period of time, as discussed before with Matt. So, because our strategy was to use corticosteroids early, with in case with tocilizumab, we use the less frequently prone position in order to avoid the neuromuscular blockade. And when we had to use, we use for a very short period of time and days, and to try to move towards assisted ventilation as early as possible. It's true that with this patient in the initial phase, we found some difficulties. So it's possible that you start, then you have to paralyze or sedate more, so you have some up and down for 2-3 days, and then you try to move to more assisted. But we try to avoid as much as possible prolonged neuromuscular blockade.
Good. Now I have here some 10 questions. Then you can go, okay? I think I can combine these 4 questions from Onur Kubilay Sever and Ali Fuat Erdem. Which ventilator do you use? Is there any specific mode of ventilation that you would prefer? B-level, and Ali Fuat is asking APRV for the patients with very low compliance and severe hypoxia.
In terms of ventilator, we have different types, so three ICUs, and we had everything. So we have the Hamilton, we have the Draeger, we have the Mackay. So these are the most that we have. So it's not a question of ventilator. First of all, good ventilator, but it's not a problem. It's a different. Second point is that type of ventilation we used in the initial phase. We prefer to use pressure controlled. Then we move to BiPAP, but BiPAP not IPRV in terms of inverse ratio. So we start to use BiPAP in terms of time controlled and some pressure support, and we reduce progressively, or pressure support alone with this moderate level of PEEP. And then in the weaning, we use conventional. So we do not use something special. We never use a PRV as considered inverse ratio, because as you have seen from our studies, we showed that we don't need to use very high pressure in the. These are not recruitable lungs, so we have to be very careful in the ventilation. The other point is that I know that some colleagues and some friends suggested to be more liberal with tidal volume in these patients. I think this is not good. We have to use the conventional rules for other patients. So it's not because the lung is more soft in phenotype 1 that perhaps should not be even intubated. We have to use higher tidal volume. We know now that we have to be protective anyway. And so we try to use 6 or maximum 8 if tidal, but especially the plateau pressure not to exceed the usual 27, 28. So I don't suggest to be more liberal only because the compliance is better. This is a very, very sick lung. This is the tricky. This is a sick lung even if the compliance is good, because you have the ground glass. To me, the concept here again is that these patients, compared to the traditional RDS, traditional you have normally aerated and non-aerated. That's it, white or black. In COVID-19, you have white, the consolidated, the black, the aerated, but you have the gray zones. And COVID is gray, and this is always gray. And COVID, that's the point, the gray zones of the lung that you don't see with mechanics, but you see with gas exchange and you see in the lung morphology. So to me, if I can describe COVID, COVID is the poorly aerated gray, and while the RDS is the white.
I see. Okay. Again, I will now combine 3 questions from Edith, Demet, and Ömer Genç. They are about stem cell therapy, plasmapheresis, immune plasma therapy, and IVIC. And I think that's an important question. Which drugs do you prefer for sedation during non-invasive ventilation and prone position?
Regarding all the other stem cell therapy, no, there is no evidence, nothing first. We can discuss, but plasmapheresis we did not use. We use the CRT, but not plasmapheresis. I don't think there is. Immune plasma. This is another interesting. We used with compassion therapy. We did not get major results in critical care. The data available are not positive at the moment in terms of plasma enriched for critical ill. There are now recent data that suggest that plasma enriched, so with high level of antibodies, might be helpful in the very, very, very early phase in older patients, but not for critical ill. So the data on plasma enriched is difficult because it depends on the concentration of the antibodies. Not all the laboratories, they develop concentration high or low. Some they mix it together. This may be also the fact that some studies were not positive. So I can tell you very briefly, we use only as a compassionate therapy outside the ICU, but in the ICU, our results were very poor. So I discussed also with relatives of some patients. There is no clear evidence, and we don't know the effects because they can modulate the inflammatory response. We don't know if positive, negative. So we were very cautious on that. So my answer is not. We don't use routinely and not in critical care. Regarding the antibodies, we have not. This is for the future. We will see. There are some data, but we need the studies on that. Then the other was the
sedation.
Sedation, yes. We used in the early phase. We used the conventional ones. So we use propofol and morphine, fentanyl. But then I can tell you, if I can tell one drug different, we use very, very little the benzodiazepine. We use a lot, and in this patient was very helpful, dexmedetomidine. To me, this was the big difference, especially because I told you in the weaning, when we move from controlled to assisted, these patients are very difficult, probably because they have some neuromuscular problems. There is some problems also in the brain, at least in the connection problem. So at the end, they disconnect, they have asynchronous like this, and we found very helpful dexmedetomidine. So if I can tell you one drug to consider different from others is dex in these patients.
Even during non-invasive ventilation?
Yes, absolutely, yes.
Yeah.
Absolutely, yes.
Thank you. Another interesting question, interesting for me, is coming from Alper Kararmaz. Anything about mechanical power in the ventilation? Yes.
So we measured, of course, in these patients, if it depends. I mean, there are some phases it's high, the base is low. I can tell you that using the decap, when the PSO2 is high, we dramatically reduce the mechanical power. But I cannot tell you if this was helpful in some patient, in the other patient not. We are collecting the data. We were able to reduce the mechanical power. However, in these patients, I think it's very tricky because if the pressure are not so high, but we have hypoxia, mechanical power is not so high. So, but the patient is hypoxic, so this means that the ground glass is high and the patient is not good. So I think that here mechanical power can be measured, we measure it, but has to be always considered very carefully because there is this disconnection between gas exchange and mechanics. But anyway, it's a parameter that one can take in account.
Yeah, and very new too. So, okay, the next one is regarding the dependence on high FiO2. Is it only time to resolve this problem, or?
Yes, we prefer to use higher FiO2, and sometimes you must use because you have no other choice. And I think this is the way that you can follow the patient, because unless you cannot go down with FiO2 means that these areas are affected. And the problem is that if you do not improve within the first 15 days, then you get problems because this area becomes consolidated. I show you that there is no more structure in the lung. The healing of the lung is difficult, and the weaning might be even impossible. But we never care too much about FiO2. So even for a longer period of time in these patients.
Good. We still have some questions, but we have only 10 minutes left, by the way. But 2 questions from Menekşe. She's asking first of something about restrictive fluid therapy. So let's say something about fluid management in these patients. And the other question from her is Any comment on ECMO, veno-venous or veno-arterial?
For fluid, I think that at the beginning, the idea was to keep this patient very dry because the idea was like an RDS. But as I show you, this is not like exactly like that. So we, of course, you know, fluids dry or wet is always difficult not to define. But I can tell you that we don't try to be very, very, very dry. That's my point. So to be not too much, but not very, very dry. Because the problem is that the risk is to have renal insufficiency. So we try to avoid renal insufficiency, and so the lung, at the end, the lung here, as I show you, is not a problem of alveolar capillary membrane edema. So even if you have a little bit more fluids, is not, in my opinion, is not a problem. You can preserve in part also the kidney. So the answer is that, of course, there is no targets now for volemia, but not clear targets. But we don't try to be very negative, okay? Some negative, but not too much. I know that is a very general answer, but I think we understand each other. This is relative to fluids. Also because they don't have hemodynamic shock. So, I think we have to be, and the risk is pulmonary thromboembolism and microembolism, that if you are very dry, and the kidney.
And one question.
The ECMO was ECMO. There are. We did ECMO. We did full ECMO and respiratory dialysis. Full ECMO. I can tell you that we only did ECMO in patients that were admitted after 7 days of mechanical ventilation, because we receive also patient. Oh, I can say that our results with full ECMO were not good clinical results, and the time of ECMO was very, very long, months, and a lot of ethical issues at the end. Okay, so at the end, ECMO, in our experience, as we used, and I can say that we have a very good team for ECMO, so no complication related to ECMO, so only complication related to the disease, but for ECMO, no problem, and was not very good. So my feeling is that, or you use full-blown ECMO very early, so within 24, 48 hours, as they did the French. They say that they organize some big ICU only to do that, but this is not easy because if you have so many patients as we received, it was impossible. If I would do that, I would not have organization to treat the other patients. And I am not sure that I did better because, as I show you, we got a mortality of around 35%. And the mortality of ECMO is 50%. And all our patients were very severe. So I'm not sure that ECMO can be even more benefit. This is the first. So my issues, our results were not very positive, at least in the later phase. So if it's some effect is very early, but it's very difficult to organize. Regarding the respiratory dialysis, of course, I have no randomized trial, but we did a lot, especially in this second wave. And I can say that at least 50%, now we are collecting, of course, all the data. 50%, so in all patients, we manage a better, more less injurious ventilation. And at least 50% of patients that we believed without any chance, they survived. This is not randomized, very anecdotal, but the CO2 removal helped us to better tailor ventilation when PCO2 was a real problem. So I think this is something to be considered in these patients. Connected or not with the renal machine. I show you in the slide, no? One individual, we use the Estor, but anyway, and the Prolong or attached to the renal machine. Okay.
As you say, in late phase, like fibrosis, we don't have, as I know, respiratory dialysis. Mm-hmm. What do you prefer us to do when we have hypercapnia?
Hypercapnia, when you have hypercapnia, this is a problem. There is nothing to do. No, nothing. We know we had patients at pH 7 and 120 PSO2. Yes. In that case, we decided we started to use the CO2 removal. There is no. You are against the wall.
Okay.
I know the situation. So with normal management, we tried everything. The expiratory ratio, there is no effect. There is only one possibility with CO2 removal, otherwise no chance.
For the fibrotic lungs, do you use or prefer any new generation of antifibrinolytic drugs? Or let me ask it generally, if the fibrosis is more in the foreground, do you have any medical recommendation maybe?
No. Actually, we use the corticosteroids I mean, this is the issue. That the difference of what we did and what the British did. And I don't know if there was, unfortunately in Italy, it was not possible to do drug study due to the regulation, only physiological. Anyway, the dexamethasone, as you remember, is 6 milligram, which is equivalent to 30 milligram methylprednisolone for 10 days. That's it. So it means that the hypothesis is only against the inflammatory mediators, okay? And not much fibrin. Our strategy was to use 1 milligram per kilo methylprednisolone, which is equivalent to 12 dexamethasone, and then taper off at the second week and taper off third weeks. More related to this issue of fibrosis. I don't know what is better. I think that a more prolonged taper off is better from pathological point of view, but of course we have no data. We try to prolong. In fact, I personally, I don't know, probably we need more studies. I have no data on that. We use methylprednisolone. I showed you that we got data exactly as they did in the dexamethasone. So I think that now we use also dexamethasone, of course, but we are always not much convinced. To me, it's a lower dose at the beginning and for a shorter period of time. If we believe in this fibrotic issue, we have to continue at lower dose for at least 10 days more. At lower dose. That's what we did. But of course, I don't want to recommend something that is outlined out of the guidelines. I showed you the CT scan of patients outside the ICU. They are not normal. This was just an example, but we have almost 30 patients. We did the CT scan within the first 10 days after extubation, and we're all exactly as I show you in the slides. So the lung is not good. Then improves with time, but we don't know if we give some corticosteroids at low dose may improve better.
Okay. You have already mentioned something about your NO experience, but there's still a question about your inhaled NO experience. So
yes,
you recommend us?
No, we used, I mean, this is the other paper that I show you in the terms of rescue. And we found, of course, it's not a magic bullet. We found that there were some patients who improved, some patients did not. No patient deteriorated. So in patients who improved, we liked because it was possible for, especially in the initial phase, to have 2-3 days to improve oxygenation and then to start to improve the patient. So I think that I'm not saying that all the patient needs nitric oxide, but I think it's a drug that should be considered also in proposition we used. So when you are very tough in terms of oxygenation, I think is not something not to be considered. I know that some people say, no, nitric oxide has to be, no. As I showed you, there is an improvement in oxygenation, more or less as we did in PRONA, and so it's a drug that we have to consider. It's not a recommendation. It's something that, in my opinion, we should have in our drug of armamentary. We used that at 5 to 15 ppm. We did not use a very high dose. I know that there is a group in Boston by my friend Berra who used 250 ppm, very, very high, in order to kill the virus. But this is another issue. We did not use also because it was not possible in our, but we used at the traditional level from 5 to 20 ppm. No problem of pulmonary problems, whatever. And this is independent from pulmonary hypertension. This is only to redistribute the blood flow peripherically. So we have not to confound the use of nitric oxide here, and then, in my opinion, and use in RDS. In RDS is mainly for pulmonary hypertension. These patients, very few, they have pulmonary hypertension, because if there is a peripheral microthrombosis. So it's a completely different use as compared to traditional RDS. But there's a rescue therapy, of course.
Before we finish, I would ask Nahid whether he has some other questions. Nahid?
If you have time, maybe I can ask about pneumocystis carini pneumonia. Clinically causes similar perfusion defects to COVID-19. That's also relatively high compliance patients with PCP I can observe.
And also respond to corticosteroids.
Yeah, they respond very well to the corticosteroids. That's a clinical entity. That's a different pathophysiology of ARDS form, I can say. But I want to ask you, we have some patients that we are continuously follow them hypoxic at the beginning of the disease, that you proposed just 3 sessions of prone position in most of the cases. But we are observing that in these cases, when we get them to prone position, we decrease FiO2 to lower than 0.6 levels. And when they get them supine, we are using 16 hours periods as the last study proposed. When we get them to supine, they severely deteriorate and we increase their FiO2 levels, and we do not have any high peak levels to use in these cases. So maybe we are using more prolonged prone position than your suggestion and more sessions than your suggestion.
No. I'm not saying that we are not using. It's a maneuver to be considered. I'm not so sure that the response in terms of oxygenation in the pathophysiology of the response is so similar to the RDS. I'm not saying that we are using the prone position. Our experience was that was helpful as a rescue maneuver, but was not so exciting, so nice. In RDS, I remember we had 80, 85 PO2, and some patients you go to 200, 250. Here was more, in this patient was more difficult to find such response. That's what my point. So you have a response. I show you our response in PO2 was between 80 and 110. So we never observed so dramatic, even in prone, so dramatic response as we were used to observing the RDS. Of course, it's better than nothing, but that's my experience. Then, of course, can be different from centers. I was less excited as compared to the traditional RDS, but I'm not saying that we should not use. It is a very good maneuver. But we have to remember one thing, that if we prone and we see that when we reposition supine, the patient does not improve too much, that we have to pay, because to me, the issue is that we have always to at least to remember that when we prone the patient, we have to pay something, which is paralysis, no assisted ventilation, like this. If we believe that this is for that time of period is more beneficial, is okay. But I think my only question this evening is to say, okay, it's good, but at least we have to think that we have to pay something. If we believe, and to always to balance the two things. If we believe that what we are to paying is better than what, okay, but we have to think that we have to pay some. Otherwise, to me, the risk is for so many colleagues, okay, prone, because prone is good, prone, this is RDS, and we prone everyone. Yes, but here, if we don't see any improvement, especially we should stop, because at the end we have to remember that these patients have, because the difference to me is that traditional RDS, we don't use corticosteroids in all of them. Here we use all of them corticosteroids. And the combination corticosteroids and neuromuscular blockade is not good. And in fact, one thing that we only partially discuss is the neuromuscular problems of these patients after 15, 20 days, also in terms of rehabilitation. So I think it's something that in this patient we have to consider more carefully than traditional RDS. This is only my concept. It's not against, I'm not talking against.
Thank you, Pelosi, and that's all for me, Mert. The microphone is yours.
I think we have to finish now. And now that was
the ladies behind
that's our daughter and her friend. So thank you very much. We have had up to 230 participants, and that was a great, and I think everybody is satisfied. I hope so. At least we are satisfied here. Thank you very much. You are type 2.
Thank you. And Ahit and Mert, I can say that I sent to you again a revised version, and you can share the slides to everyone. There is no problem at all.
Everyone needing the slides, I can send them. I can forward them.
There is no problem. No secrets.
Okay.
Ciao.
Ciao.
Thank you. Bye bye.
Ciao. Bye. Ciao.
See you soon. Congratulations.
Ciao. Thank you.
Ciao, man. Thank you.
And we hope to see you in the future in Istanbul. We hope, or in Turkey somewhere.
See you.
Eat a good kebab, Turkish kebab, okay?
Something to drink.
And the drink, the drink. Ciao, ciao.
Ciao, ciao.
Ciao.
Ciao.